Good afternoon, ladies and gentlemen. I want to go ahead and call our Help Subcommittee meeting to order. We're a couple minutes late. We've got some folks that will be coming in that were in some other meetings, and then we had to have a little technical help to get us going here, but we're ready to start. So without further ado, we're going to call on Commissioner Frank Berry to make a presentation. Commissioner.
Thank you, Mr. Chairman, and it is great to have you back. We missed you the other day, so thank you. Yeah. Lisa Walker will walk us through, our Chief Financial Officer will walk us through the dollars. I thought if it would be acceptable to the members of the committee just to give a little bit of an overview of some of our budget requests and a little bit about our department. And again, if we can certainly reach out to any member who has more specific questions about the department. And Brandy Sylvan is here. Where are you, Brandy? If anybody needs to get in touch with us, certainly reach out to Brandy. Before we get into our presentation, I wanted just to revisit our purpose very quickly: shaping the future of a healthy Georgia by improving access and ensuring quality to strengthen the communities we serve. The department has 5 major divisions. The Division of Medical Assistance Plans, otherwise known as Medicaid; State Health Benefit Plan, many of you know that as SHBP and may get your insurance benefits from us; Health Facility Regulation, otherwise known as HFRD; State Office of Rural Health, which is our only outposted office that we have, and that's down in Cordele; and then Health Planning, and many of you will know that as the Office of Health Planning or Certification of Need. That falls under that. I want to remind everybody that there were 61,000, almost 62,000 Georgia Medicaid births in 2018. 1.9 million people are enrolled in our Medicaid program, with about 1.3 pregnant women, children, and youth, and 519,000 age, blind, and disabled citizens. 52% of Georgia's children receive Medicaid coverage through us. The total number of Georgia Medicaid and Peach Care for Children expenditures exceeded $10 billion during fiscal year 2017 and 2018. Switching over to SHBP, 665,000 covered lives. That's people that are enrolled in the program and their dependents. And then I think this number is really fascinating. Health Facilities Regulation, we license over 24,000 healthcare facilities. And then the State Office of Rural Health administered almost $17 million of federal funds ran through that office to help identify some of the challenges and come up with solutions to some of our rural healthcare challenges. And then last year we did 82 Certificate of Need applications. So it's a fairly large department. And it's a lot of moving pieces and parts. When you try to figure out how to make the department work as a team, when you have such specialized areas. But what I'm really excited about is that the team at DCH has really come together to focus on really 4 primary areas that we have spent the last 2 years focusing on. Accountability is the newest one, and so we look at it this way. Our number 1 priority was communication with our stakeholders, communication with you all, communication with people that desperately are in need of care, and many other people. Customer service is at the core of everything that we do. We certainly recognize that we have a long way to go. Very specifically, for instance, from a customer service perspective, when somebody calls with a challenge accessing their health care with the SHBP program, they need to be able to talk to a live person. And we're taking up that issue within the department. We hear the frustration from people when they don't get a live person on the phone. We also hear from many providers across the state about what it's like when you're trying to become a Medicaid provider. And so we've gone down the path from a customer service standpoint of looking at administrative simplification. How do we make that provider packet more manageable? How do we make it from being this thick to this thick and potentially being automated? So those are some of the things in that area. And if you're a family member or a person seeking care, how do we make that easily accessible for individuals? We've talked a little bit about and happy birthday, Madam Chair. How do we make it easier for families who are trying to access one of our waivers? And we heard very clearly, for instance, on the Katie Beckett waiver, and I know I've talked about this before, but this gives you a glimpse into what we're trying to accomplish. Katie Beckett waiver family member came to us and said, when you require us to resubmit an application on an annual basis, we go out and it takes us 365 days to get ready for that application to be submitted. That night that we submit it, we go out and we have hard partying that we do. And the next day we wake up in the morning and we realize we only have 364 more days before that application is due. When Blake and his team heard about that, Blake Fullenwider, our Chief Health Policy Officer, when we heard about that, we explored options to remedy that, and we were able to come up with a plan that would allow families to only have to apply every 2 years instead of every year. The reduction in that administrative burden to those families meant so much to them that they no longer had to worry every single day to prepare for that following year application deadline, that they now had 2 years. So it's things like that that we're trying to break down the administrative burden to individuals, and it really gets down to an individual basis. And then teamwork. Inside the department, we're really focusing on how do we work better as a team? How do we count on our general counsel to help us across the agency, not just in certain divisions? How do we make certain that our chief financial officer touches every aspect of the agency so that the information that you all get is good, clean information? So we've really put in these 4 pieces, and then finally the accountability piece. How do we hold each other accountable within the department? How do we hold providers accountable, and how do providers and stakeholders hold us accountable? So that open lines of communication is really key to the accountability piece. So communication, customer service, teamwork, and accountability are what are really driving our department right now. And I believe that we have 1,050 employees who, if you ask them what are my top priorities, they could recite those to you. And that's taken a little bit of time, but I'm pleased to say that our team is really working hard to get us there. A couple of issues before we get right into the budget numbers. Some challenges that I see for us moving forward, and some of our budget items will reflect this, both on Amended 19 and then as we move into 20. Information technology infrastructure. If you think about it, our infrastructure in the department is about 20 years old. It was put in place almost 20 to 25 years ago, and if we're going to be prepared for the healthcare environment of the future, we have to modernize our technology infrastructure. Medicaid transformation. Many of you know there are a lot of discussions going on about Medicaid right now. You'll see $1 million in our budget. We are so grateful to Governor Kemp for putting this in there. It is a first bite of the apple of what we may be able to do to look at how we modernize Medicaid, and it's exciting. And I don't know of anybody who has been around for a little bit of time who isn't excited about this, and we are excited to be at the table in this discussion. Continuous process improvement, and that goes back to the ongoing reduction of administrative burden. We have to do a better job in particular of getting Medicaid providers who are people who are interested in becoming a Medicaid provider, that we support them. We need more of them. Healthcare analytics and reporting, as we move forward with some of the Medicaid and SHBP challenges that we're faced with, we need to be able to have good, clean data to help inform those decisions and discussions. And then the certificate of need. I know that there is a tremendous amount of discussion going on about that. Our biggest priority is to be at the table to help inform those discussions, and then we follow what you all tell us to do and that the governor signs off on. We don't really take a position one way or another. What we can do is help inform those discussions. So we're excited about the work ahead. Our 19 amended budget is not extremely complicated. We can certainly answer questions, and Lisa can walk us through. So Lisa, I'll turn it over to you, and then we can answer whatever questions may come up. Thank you, Mr. Chairman.
Good afternoon. I'm presenting the Department of Community Health budget request for the amended fiscal year 2019. And usually we like to give an overview of what our current budget is and where we stand as it relates to our current budget. Department of Community Health for fiscal year 2019, we are appropriated $15.5 billion in our agency, with $3.3 billion of that as state funds. The majority of that appropriation is actually spent in our benefits program. That's 97% of it, and that's the age, blind, and disabled and the low-income Medicaid program. And the remaining is spread throughout our administrative offices and also our dental and pharmacy boards. I'll start by going over the amended year physical request. I start by referencing the tracking number so that you can, if you have a tracking sheet, so that you can reference the tracking sheet along with each item. I'll start with our Department on Administration and Program Support program. And the first of those items is item 17.1.2, and that's for background checks. And those background checks is for staff at the Department of Community Health to do background checks for long-term care facilities, and those are employees at that particular facility. And that request is in the amount of $495,264. The next item is 17.1.3, and that's for Medicaid Management Information System, which we reference as MMIS. And that's a system integration platform that's transferring our current system to a modular system. I reference it as subsystems that will process either claims or do financial parts of the system. And that request is in the amount of $5,696,419 for that request. The next item is item 17.1.4, Healthcare Facility Regulation Process Improvement. And that particular item is for the improvement of the operations for healthcare facility regulations. That's our nurse surveyors who go out and survey nursing home and other long-term care facilities in the state. And that request is for $152,000. And it covers automated scheduling system. This will help the nurse surveyors schedule their surveys as they go out to do it to help reduce travel expenses and lower administrative burden and improve the efficiencies of those nurse surveyors going out doing those surveys. This also includes timekeeping system to help them better track their time so that we can actually get federal reimbursement in terms of managing their time of their surveys and perform better forecasting as it relates to how that cost is generated as it relates to their time doing surveys. Access database conversion is also a part of that process improvement. And the access database is actually the capability to give program managers quick access to critical data so that they can utilize that data to better inform and make decisions. And the last of that is actually implementing an online license application process, which currently is not automated. It's a paper process, and this is just help healthcare facility regulation improve their processes in terms of operation. The next item is 17.1.5, external Medicaid consultant. And this particular item is to actually have a consultant explore options for the purposes of drafting and prepare waiver policies for the recommendation and approval of the governor. And the amount of that request is $1 million. The next item is 17.1.6, and that's utilize existing funds for DDI of caregivers registry. And that is a yes item because it means utilize existing funds that we currently have. And that was to design, develop, and implement a caregiver registry for those caregivers in the state. And the next item is 17.1.7, utilize existing funds for expand Medicaid asset verification system. And the asset verification system is part of the gateway system when beneficiaries have to be determined eligible. All assets are looked at in terms of making that determination. And currently, the only part of the system that is programmed to do that are those who are in institutional category. And this is to go forth to put it in all categories of services within the population in terms of eligibility determination. And that's also a yes item because it's utilized existing funds of $591,000. The next item is program is Healthcare Access and Improvement. This is actually the State Office of Rural Health, and that's to increase tobacco settlement funds for the Champions of Children program in the amount of $480,000. And this is a contract they have with Easter Seals in order to service those most fragile children who are in the state. The next program is Indigent Care Trust Fund, ICTF, as we reference it, is for disproportionate share hospitals. And this is the portion of the state dollars that are appropriated to draw down federal funds for those private hospitals who serve indigent patients in the state of Georgia. And that amount is in $18,766,884. Next programs that I'll be covering are age, blind, and disabled, and low-income Medicaid. It actually goes into our benefits programs. And the first of those items are benefit growth, and it's 17.7.1 and 17.8.1 in both programs. And the benefits growth, this is every year we do projections to look at utilization of services in our benefits program. Also, we look at enrollment trend and actually general medical inflation that goes into that benefits number. And the request is for $33,745,829. The next item is 17.7.2 for Medicare Part B. And this Medicare Part B is for dual eligibles, both Medicare and Medicaid. And this is the portion that pays on behalf of those dual eligibles. And that amount is $1,998,764. The next item is 17.7.3, 17.8.2 for gene therapy. 2 drugs were approved in terms of gene therapy by FDA, and the Department of Community Health is actually adding that onto as a benefits in terms of those beneficiaries, and that will remove a cap. We actually had an outpatient cap as it relates to that particular coverage, and we're removing that cap so that gene therapy can be covered. And this particular therapy is for inherited disorders, certain types of cancer, and certain viral infections. The next item is for 17.7.4, 17.8.3, and this is for the IPPS Phase 3 module. And what the IPPS Phase 3 module is that this is a reimbursement that the department actually reimburses hospital for inpatient hospital stays, and we are actually proposing to update the reimbursement system so that those hospitals will not have a significant impact for those who have high claims volume that come in as it relates to IPPS. And that request is for $4,637,616 for the IPPS item. The next item is 17.7.5, long-term acute care. We reference that as LTAC. And this is proposing to enroll new LTAC facilities and intermediate rehabilitation facilities as Medicaid providers. It'll be a total of 10, 7 LTAC facilities and 3 intermediate rehabilitation facilities. And that request is in the amount of $2,504,548. The next item is 17.7.6 for Part D clawback. Is this for dual eligibles also to pay for prescription coverage? And the request for that amount is $1,088,264 for the Part D clawback coverage. The next item is 17.8.4, and this is just a replacement of state dollars with tobacco settlement funds that goes for regular benefit coverage within the benefit programs. And that's ABD and low-income Medicaid of the amount of $1,019,235. The next item is 17.8.5, this hospital provider fee. You see a reduction of $14,535,914. That's actually not, is a revenue estimate that we give to OPB each year in terms of how we have previously collected revenue for the hospital provider fee. When you see our fiscal year 2020, you'll see that go back up. And even with this estimate and projection, it's still, we might collect more than our reduction that you see coming into the budget, but we have to give a revenue projection in terms of the overall state revenue impact. The next item is statewide changes in various programs. These are statewide changes that the Governor's Office of Planning and Budget usually appropriate to all state agencies regarding general operation. And the amount for the Department of Community Health is $11,771, and that's for DOAS self-insurance programs within the department. That covers our general administration and our benefits program. The next program that I'll be covering is state health benefits. And within the state health benefit, you see yes items, and that's because that's other funds that go in to cover those services within state health benefits. But I make reference to each tracking item and go over what the coverage is for those items. The first of those, 17.10.1, reflect updated growth. And this is similar to Medicaid. We look at utilization. We also look at trends that is affecting the state health benefit program. And this is a yes item to add additional dollars in state health benefits of $162,183,668. The next item is 17.10.2, to reduce funds to reflect savings for Medicare Advantage. Each year we renegotiate certain coverage within the state health benefit plan, and the premium rates for Medicare Advantage actually decreased this year, and that's to reflect those savings within the state health benefit plan of $41,975,000 within state health benefits. The next item is 17.10.3, increase funds to reflect enrollment growth for mental health parity, and that amount is $3,638,000. And this is to add additional coverage within the state health benefit plan for residential treatment centers, a methadone coverage, and also applied behavior analysis within state health benefit program. And that actually concludes all the budget request items for the amended year as it relates to the Department of Community Health, but we're welcome to take any questions.
Okay, thank you, Lucy. And we do have some questions. Representative Hughley has a question for you.
Thank you, Mr. Chairman. I just want to make sure that I'm clear. This $1 million is just for somebody to develop a waiver package for us? Is that what we're paying $1 million for?
So in order to do a potential waiver submission, working under the CMS guidelines, it's a pretty massive undertaking. There's a tremendous amount of analytics that goes into that. There's actuarials that go into that. And in order to successfully submit, most states that have been successful in their 1115 waiver submissions have used some type of nationally recognized or well-recognized consultant to help them submit those waivers. It's a pretty comprehensive, it's a application that's about that big, and that's something that we would absolutely welcome to have that expertise walk us through that process. So yes, to answer your question, it is for a consultant or a firm to help us with that waiver.
Okay, I have one other question, if you don't mind, Mr. Chairman. I appreciate the fact that you're committed to customer service, and one question that I've been asked is that when organizations that are serving constituents and trying to help them enroll their children in Medicaid, they find that the website is closed or inoperable after 5 o'clock and it's not open on the weekends. Is there a way that we can address that to make it more user-friendly? We can absolutely. That's a great example of that administrative simplification, that we can look into that and see if there are options with that. Lisa?
Actually, that's the gateway system, and that's for all application process, not only Medicaid, that's for food stamp, TANF. I can't speak on the behalf of DHS because they have the oversight of Gateway, but Gateway operates within a certain time frame and within a certain amount of hours.
From a Medicaid perspective, if there's ways for us to tweak the Medicaid part of that, we can absolutely look into that, and we'll get back with you on what the options are.
Thank you.
Thank you.
One of the things on that you touched on also, Commissioner, was the credentialing process, and I know
Yes.
that y'all have made tremendous strides from where we were and how long it took and how many forms you had to fill out and all, but I still think that we got some more tweaking to do, and I know you're committed to making that happen.
Yes, sir.
Okay, we have a question. Representative Gardner has a question for you. Yep.
So certainly we want to recognize the hard work that Grady has put into looking at this issue. I want to remind everybody that, and this is said with all tremendous amount of respect, there's no such thing as a Grady waiver. It's a state of Georgia waiver. It's a Medicaid waiver. And so one of the things that we have to look out for is how does this impact the whole entire state? Now there could be some real benefit, and I think that there are some aspects of the work that Grady has done that are very interesting to the state and may be able to be looked at of how you roll that out across. We'll be working very closely, of course, with the governor's office to see which pieces and parts could impact the most individuals. The care coordination is critical. We need to figure out, if we asked everybody in this room, what are your top 4 areas as it relates to what a waiver should be focused on, we would probably have about 50 different answers. That's another thing that the consultant can actually look into, is what is the problem you're trying to solve? And is it financial? Is it clinical services? Is it lack thereof? And who's the target population that you're trying to address? We need to look at all of that information. I think the Grady work has helped inform that discussion.
Sorry, I mentioned just Grady because I know that
Yeah.
several other hospitals working.
Yes.
For me, care coordination is a key to making the system work.
It is. Yes, ma'am. You're exactly right. The care coordination piece, and that's something, a consistent care coordination definition across the board would be very helpful. And we're working with our partners right now on that very issue. So thank you. But again, our real focus is certainly understanding what's going on in Fulton County, but then looking at some of our rural areas in the state and how do we make certain that we're getting people covered out there as well.
Okay, we have another question from Representative Taylor, who's here celebrating part of her birthday with us today. So happy birthday, Representative Taylor.
See, we were hoping that in 10 years we could look back and say we were doing this House Appropriations meeting in the middle of a blizzard, but we get to say that we were here for your birthday. So that's almost as good.
It doesn't hurt too bad. Thank you. I do have a couple of questions.
Yes, ma'am.
It has to do with the contracting that we do, and I have several issues. In the rural communities, we're having trouble getting providers, and we're seeing some of the contracts that we have with the service providers, the payers, asking for a lot more additional information. They're just sort of changing what they're wanting. They're asking for more information, and that's a concern to me. It's going to affect particularly some mental health providers, and we might need to get together offline and talk about that. And it goes back to that clawback for Wellstar for drugs for Part D. Talk about PBMs and the way they're doing clawbacks.
Yes, ma'am.
Maybe I'd like to look at that. But also what we can do for contracting with the medical providers, and again, our rural communities are having, it appears, more and more trouble keeping them. And some of it has to do with the contracting efforts that we are doing. We're causing more hassle than needs to be there.
Madam Chair, it would be helpful maybe if we do come over and get specifics of where the pressure points are, because that'd be great. Brandy can reach out and we'll either see you this week or next week.
Has I got it? Yeah. Thank you, Mr. Chairman, and thank you, Commissioner and Ms. Walker, so much. I have a couple of questions. I'm going to begin with something that relates to a previous year's allocation. How are we doing with HFRD? We made sure that we increased salaries to get more, to find it easier to hire registered nurses at healthcare facility regulation. Has that been helpful in solving that hiring issue we had?
Yes, sir. So 2 years ago when we started, we had a staffing crisis in HFRD. Right. And thanks to you all and the Governor Deal then, infused some dollars so that we were able to recruit and retain staff at a higher level of pay. I think we were paying our entry-level nurses in HFRD around $50,000, and the infusion of dollars brought that salary up to $65,000 to be much more competitive with everybody else. For about a year and maybe 3 to 4 months, we were close to capacity. We recently have, and again, as you know, I'll tell you how it is. We recently have had some vacancies again, and so it is a challenge for us to keep fully staffed. Part of the issue, of course, is the workload requirements are pretty high. It's a very, very stressful job, and it's a challenge for us. So we are addressing the vacancy rate. We are still in compliance with our federal regulations from CMS. However, we are down staff right now. So the immediate result was that it paid off, and we saw a tremendous increase in our ability to recruit. And then after about a year and a half, to be able to retain has dropped off a little bit. It's something that we're keeping a very close eye on, but it is a challenge for us.
Well, thank you, sir. And we need to know if it continues to be a challenge. It sounds like it was effective, though, and actually that is now a very fair. If you look at state average wages for RNs, I track pretty closely. That's a pretty good wage.
Yes, sir.
So perhaps there may be other issues, but likely that's not the issue today. I'm glad it's been helpful. There's a couple of questions. So it was mentioned we've got about $1.5 million for HFRD in this budget here. For scheduling and timekeeping efficiencies. So I wanted to make sure none of that is for wage improvements in any way for staff.
No.
That is more for systems,
yes.
To make sure I understand.
Correct.
That, to better, so that they can better manage their schedule and so forth?
Okay. So CMS has certain guidelines that they give out that we have to follow. And part of that is the time study, so that they require random moment. You may have heard at times of random moment time studies. You may have heard of other types of time studies. Right. This would help keep the department in compliance with some of those CMS regs. Okay.
And then lastly, so the money, about $591,000, Medicaid asset verification system. So this is, this again is software or technology that's available so that we can more fully, I'm thinking MAOs who are going through approval processes, right, with ABD, trying to make sure that people are promptly evaluated for whether or not they, on the financial side, on the asset side, are eligible.
The current system is still Gateway. It's just that a portion of Gateway was just modified for institutional, not for all the categories of service. And this will go forth to modify the system so all categories of service for a more expedited determination for those populations.
Okay, that helps me. Expediting that process is very helpful.
Yes.
And also that it would be more accurate, because we do know that so many people do try to game the system. And it's why it's so important that y'all vet individuals so carefully. And so if it makes it more accurate and more efficient, that's a a great goal.
And if
Yeah,
I could add
thank
just
you.
one thing to that, I know that there's a history of a perception that the agencies don't work well together or don't coordinate much. Under the leadership of Commissioner Crittenton, the two agencies who are focusing on Gateway really work closely together. We are in contact sometimes as much as 4 or 5 times a week, talking about challenges and trying to address those. So I just want to recognize the leadership of DHS as they have implemented the Gateway system, and our team who participates in keeping it rolling. So it is a nice partnership.
Thank you, sir.
Thank you.
Mr. Commissioner, I heard that you say the fine young man from my hometown, Gainesville, Georgia, has worked on this Katie Beckett waiver, which we appreciate because this has been an issue over the years. You know, we have kids in this thing that have non-correctable disabilities, such as spina bifida. Can we even enhance that more other than the 2-year window, maybe even consider maybe 3 or 4 years for these kids?
So
I would ask you if you could do that. And also, my question relates to that, and that is, when they make applications, what is the time period before they hear back and that waiver is back in force? Is it weeks? I know years ago, we were talking about 3 months, which seemed like a long period. Every year, the kids went 3 months without treatment, but yet the state was paying for 12 months of treatment.
I'll get you an answer on the
Yeah.
time frame, and we'll get that back to you. I don't have that at my
Okay.
fingertips, but I'll get back to you. The 2-year window for the Katie Beckett was our first go at looking what would happen if we moved from a year to 2.
Right.
Were there issues with audits?
Right.
Were there issues? So CMS will still do an audit
Right.
to make a determination. As we made the agreement that we would look at it first from a 2-year standpoint, if things move smoothly, then we said we would revisit it and see if there were exceptions that came in, and if not, are there opportunities for us to even extend that further? So we're always looking at that. We've not made a decision to extend it yet, but when we first moved to the 2 years, it's up to the state in a lot of these waiver discussions. It's up to the state of how long that window is. And the caution was that if there was an audit, the state is on the hook for that.
Right.
And so if we see that there's not really been any real challenges, and we could entertain what would happen if we went to 3 years, or if there's a certain type of a condition, what would happen if we went even longer? So we're open for those discussions with the caveat that we always have to make certain that from an audit standpoint, we're not putting the state at too much risk.
I guess we could put those in categories, which would be what we approach.
Right,
It's not different, whatever, so we know that patient's never going to recover from that.
right.
I know they age out with some treatments, but they don't age out.
And that's one of those where if we want to have some further discussion, we can certainly come over. Blake can come over and we can talk through some of that, and we can bring some of our experts from the department over to have those discussions, and we would welcome that.
Okay, so you know, well, we just got another question here from Representative
I just want to make
Hughley.
sure everybody had opportunity to ask a question, but I still have one more, if you don't mind, Mr. Chairman. Thank you so much. On your Champions for Children program, working with Easter Seals, I'm excited to see that, but how much of the need are we addressing with this amount?
Go ahead.
That's a particular question we'll have to follow back up on, because we'll have to touch bases with State Office of Rural Health. That's how this contract is administered. So we'll have to actually look at those dollars and see how many more children that will be able to serve within the state.
And one other question, and I had a constituent to come to see me yesterday about, she's an audiologist from Columbus, about a 20% reduction that they've been given notice of from Peach State.
I just heard about this late last night, and we're looking into that, and we'll have an answer for you hopefully before the end of this week on that. We always get concerned when there are rates reductions, and we'll get back with you on what that means.
Thank you.
Thank you. And Tara, thank you for your ongoing support when you spend the time with us throughout the year. It really means a lot to us, and thank you very, very much for all that you do.
Okay, Mr. Commissioner, thank you very much. Lisa,
Thank you, Mr. Chairman,
and
members of the
appreciate you
committee.
being here with us today.
Thank you very much.
Okay, next we're going to hear from the Department of Public Health, Dr. Pat O'Neill. Ask him to come on up.
Mr. Chairman, members of the committee, thank you for allowing us to present today. Our presentation is going to be considerably shorter, but I think it's also very important. If you would look at page 56, 38.1.2 first, and what we're asking for there is really for Georgia Core, the Center for Oncology Research and Education, which is a very important partner for us as we look at cancer throughout the state of Georgia. What we're asking for is an increase in tobacco settlement funds for an online genetic screening tool, and basically looking particularly at hereditary breast cancer as well as ovarian cancer. And the next item is what all the agencies are having to deal with, that's statewide changes. Agency premiums for us, for Department of Administrative Services administered self-insurance, that amounts to $117,051. For core, the amount was $72,000. The grand total, $189,051.
Okay.
And this just sort of gives you the general picture of our annual operating budget.
Okay. Do you have any questions for Dr. O'Neill? You did such a good job, there are no questions. Oh, I'm sorry. Excuse me. Representative Gardner has a question. Try that mic again. Let's see if that works.
It really is a very important issue. I think you're well aware that in Georgia we have major problems with maternal mortality. And I think we're doing a pretty good job of addressing that in terms of the two major causes, essentially hemorrhage and hypertension. But the mental health side has been somewhat neglected. And this grant would have provided for the ability to screen individuals that were pregnant for possible mental illness with depression specifically, or with addictive disease, many other mental abnormalities as well. And the grant would have provided a little bit over $1 million. I don't have the exact amount, but it was less than $1,100,000. And I do think that if we are really going to continue to move the needle in Georgia, which is, you know, it's really embarrassing when I meet with cohorts from other states to share with them the mortality rate for women here in Georgia when they give birth. Yes.
Thank you, Commissioner. Real quick, just wanted a real simple explanation. The online genetic screening tool for breast and ovarian cancer sounds fantastic. Can you just help explain that to us a little bit, very briefly? How that might be available to our constituents?
Essentially, this is an evidence-based tool that will give us a pretty good idea when there is a strong probability that a pregnant lady may have the genetic makeup such that essentially she is very prone to develop either breast or ovarian cancer. And once the screening is done, then we have to go further with that. Actually, the provider goes further with that to look specifically at what the genetic makeup is that's causing that likelihood or possibility anyway being increased for having a cancer.
And Commissioner, they would have access to this tool in our public health departments?
Yes.
I'm assuming in their local public health department, there would be someone there who understands how to use this tool.
Yes.
To just begin to discover the degree to which they might be susceptible. Okay.
Yes.
Got you. Thank you.
And actually, the core organization does a tremendous job working with us. We have a contract with them. And their activities in terms of trying to identify opportunities to deal with the cancer situation that we face in Georgia, even though in many situations we've seen the prevalence of cancer going down, we still do have areas where there's a great deal of opportunity for improvement. And if we can identify situations where there is a likelihood and there can be steps taken to address that ahead of time, obviously we want to do that.
Thank you, Dr. Neal. I'll just remind everybody, all we're looking at today is the amended, so there'll be some opportunities to look at these other items as once we get this done, then we'll look at the big budget and do that too. Doctor, thank you very much for being here. Appreciate you.
Thank you.
Being here. Okay, next we're going to hear from President Underwood, Mercer University, and Dr. Sumner.
Mr. Chairman, thank you for the opportunity to be here, and we appreciate the opportunity to meet with the other members of the committee as well. This is a very important proposal that we're presenting. This idea began 8 years ago when a group from Columbus came to meet with me in my office. The group was led by your colleague, Representative Richard Smith, with former State Senator Pete Robinson, with the then Executive Director of the Bradley Turner Foundation, Tom Black, and with a local community leader, Jimmy Elder, who's the pastor of the First Baptist Church in Columbus. They expressed to me during that meeting their concern about replenishing an aging physician workforce in Columbus, as well as meeting the healthcare needs of what is the most underserved region in the state of Georgia, which is southwest Georgia. They asked if we would consider launching a medical school in Columbus. They knew that we had done this before with the support of the General Assembly, this committee, and then Governor Perdue when we opened the campus in Savannah. They knew that that effort had been very successful. They knew that we had a very high retention rate among the physicians that completed our program, nearly 70% retention today when the national average is about 38.6%. They knew that the reason for that retention rate was that we only accept students who have deep roots in Georgia and a commitment to stay here and practice when they complete their program. And I told them that we would consider their request, that it was well within our mission, which is to meet the healthcare needs of rural and underserved areas of the state. I told them that it was not an easy thing to do, what they were requesting, that it would take several years and it would be challenging to accomplish this. I told them the first challenge was establishing adequate clinical rotations for third and fourth year medical students in the Columbus community. The second challenge would be facilities, and we told them the community would have to raise funds for the facilities for a campus there. And then the third challenge would be to secure operating support from the General Assembly and the governor. After I met with them, I met with Governor Deal to talk with him about the proposal, certainly not to get his support at that stage in the process, but simply to inform him of this initiative and give him an opportunity to provide input as to whether this is something that he might potentially be interested in. So we've been working at this for 8 years now, and periodically I've reported to the governor's office on our progress. We have established affiliation agreements with the 2 major hospitals in Columbus and have determined that there are a sufficient number of quality clinical rotations available to students between those 2 hospitals in Columbus, as well as the community physicians. We also have recently completed fundraising in Columbus. The community has risen to the challenge. They have secured a facility in downtown Columbus that will be suitable for a quality medical school facility, as well as raising approximately $13 million to renovate the facility. So we believe that the facility needs for a campus in Columbus have been addressed by the community. And that leads us to the 3rd challenge, and that is seeking support from the General Assembly for what we think is a very important initiative. We think it's an initiative that will be good for the state of Georgia. This will allow us to increase the number of doctors we're producing by 50%. Georgia currently ranks 39th in the country in physicians per capita. That doesn't sound very good, but we've made progress over the last decade. And I think this initiative will allow us to make even more progress towards meeting the healthcare needs of people in this state. I think this initiative will be good for Southwest Georgia. We have found that graduates of our medical school tend to locate in the area where they attended school, and furthermore, we tend to draw students intentionally from areas that are underserved. And this will provide us an opportunity to train physicians in what is the most underserved region of the state. And I think it's also an initiative that will be good for improving access to rural health. 3 years ago, we brought Dr. Jean Sumner to the School of Medicine to lead the school. I think it's fair to say that she's one of the leading experts in the country on rural medicine, and it's expertise that's acquired not by reading about it, but by her practice in Wrightsville, Georgia. And she has accomplished some remarkable things in just 3 years. We're now providing free medical school to students who are committed to rural practices. We have opened the first of what I anticipate will be a network of rural health clinics to provide places for students who are committed to rural practice to begin their practice. The first opened this July in Plains, where they didn't have a physician. We're now looking at Clay County for the second, and I've challenged Jean to reach a goal of having somewhere between 25 and 50 of these rural health clinics. Finally, I'll just mention that our rural community health expertise has been acknowledged by the National Institutes of Health, which has designated Mercer as one of the 2 centers for excellence in the country in terms of rural health, and most recently with Mercer being selected to lead the Rural Health Innovation Center in this state. So this is something that I think will be important to Georgia, to Columbus, to Southwest Georgia, and to rural health generally in our community. And with that, I'll be glad to take any questions about this initiative and invite Dr. Sumner to join me.
Representative Hughley has a question for you.
Thank you, Mr. Chairman. I don't really have a question, but on behalf of Columbus, I want to let this committee know how important we think this is not only to our citizens, but to the southwest corner of our state, which encompasses some of the poorest counties in the country. And it's going to make a big difference, and our community has shown its commitment in terms of what it has done, and we really appreciate the work that Mercer has done as well.
Thank you.
Thank you. And we might want to hear from some of our guests out here. Representative Smith, I didn't know if you wanted to say anything, because he brought his senator with him to show his support as well, and I'm assuming it's about that project. I've got it on, but it's not.
It is about this project. And Dr. Underwood made the comment that Columbus is committed to this project. We have raised $13.8 million. We also have a 70,000 square foot building designated for this project. So, you know, we've got a commitment, and like Representative Hughley said, if you go down to Southwest Georgia, there are basically three types of doctors who go serve here. One is to pay off a student loan. One is to get some kind of certification. Those two never stay. But if you select young people who have a zip code in that area, they know the people there, they want to go back home, and those are the ones who will go back and provide health care to that part of the state. Because there's parts of that area of Georgia that's a health care desert. So this is a vital project, not only in order to produce more doctors, but also produce more doctors who will go into these underserved areas.
Thank you, sir. Representative Gordon, did you have a question?
Yes, thank you for providing this kinds of training in parts of the state where we really need it. I thought that I have two questions. One is, are they primarily trained as primary care physicians?
That's our goal, is to prepare primary care physicians, and we achieve that with more than 80% of our graduates. They go into primary care, which, yeah.
I noticed on this map, in the last couple of years, we've heard something about the osteopathic schools out in Oregon.
Right.
And well, there's one in Atlanta as well. So there's one in Atlanta and one in Moultrie, but it didn't appear on your map.
Those are the allopathic medical schools that produce medical doctors. I didn't include the others, I'm sorry.
Thank you for what you're doing. It's really important for us.
Do we have any other questions from the committee? Okay, Representative Hawkins.
Commend you for what you're doing down there. I think this is a great program that you're working on. You show a lot of wisdom in that, and I also want to commend you for hiring Jean Sumner, someone I've known for many years, and I have great respect for her. When she worked with the medical board, you couldn't find a finer dean, I'll tell you.
Thank you.
Sumner, did you have some comments you'd like to make while you're here?
Well, I just appreciate the support that the state has given us. We're committed to our mission. We're serious about our mission. We're serious about serving all of Georgia, particularly rural and underserved populations. West Georgia needs physicians. We believe we can be successful. We've increased our student admissions in that area for over 100% of young people. We actually have in the first year class and the entering class 5 students from Decatur County, for example. We have students from Randolph County, 2 students coming in from Randolph County. We're going to Clay County. I'd invite you over in a few months to see what we're doing in Clay County.
Great. Jean, make a couple of comments about your 3-year program that y'all are working on now.
Through your support, and Mercer and Texas Tech were the first 2 schools in the country to initiate a accelerated track where you come in like any other medical student, and if you're academically sound, you can apply to enter the accelerated track. You finish the same curriculum in 3 years. 4th-year medical students spend a lot of time flying around the country trying to find residencies. That's not necessary because we have permission outside the match to match them with a Georgia residency. So they enter internal medicine or family medicine residencies. We've been approached in both Macon and Savannah to add pediatrics to that. We've been approached by psychiatry residencies to add psychiatrists to that. Those young people are committed very strongly to rural practice. We try to give them strong clinical skills so they'll be able to survive out there and practice quality medicine. But the accelerated track has really changed medical education for us. We get calls from around the country, people interested in our program. We also have increasing interest in it. It is really a very popular program, and those students do as well on their national boards as any 4-year student as well.
Thank you. I want to make a couple of comments. First of all, President Underwood, I want to thank you for what you and Mercer have done to produce primary care physicians who basically stay in this state and do a lot of their residency programs here as well. But I also, Gene Sumner was a champion of rural health care before most people knew there was a rural health care. So Gene, thank you for what you've done too. And they've really been a pioneer, like with this 3-year program and some of these other things too. So thank you very much for being here with us today. We appreciate your presentation, and certainly we're going to take a hard look at that. Thank you. Is there anyone else that's with us that wanted to make a comment or anything that we haven't heard from? Okay. Well, thank you very much, and we'll remember this is just the amended budget, and once we finish with this, then we'll take up the big budget. Thank you all for being with us. We'll adjourn the meeting.